Okay, welcome everyone to the National Hypertension Control Roundtable Fireside Chat. My name is Jenny Bogart and I am the Executive Director for the Roundtable. I am thrilled that you are all joining us today to talk about self-measured blood pressure monitoring and listen to our three wonderful presenters on how they're addressing that and promoting that. A little bit about the Roundtable for those who may not be familiar. We are a national coalition where we have multiple members from a variety of different sectors and organizations that are all dedicating their professional careers and their work to improving hypertension control. We had our annual summit earlier in September where we had such an enriched dialogue where we talked about a variety of different topics, from the inequities around hypertension control to addressing innovative ways of how we are implementing programs throughout our communities, cross-sector partnerships. And what we really wanted to do through these Fireside Chat series is to continue that conversation throughout the year. So while this may be our first Fireside Chat after our annual summit, it is by no means our last. We are hoping to schedule our next one in early next year, and we invite all of you to attend and join us for that as well. If you're not a member of the Roundtable, I also invite you to join so you can be part of this wonderful group of experts, and also encourage you to sign up for the newsletter so that you can receive additional information and know when we're scheduling our next Fireside Chat. So I hope you all grabbed a cup of coffee or hot tea. I know it's rainy and cold here in San Francisco, so I invite you now to join our Fireside Chat. And I encourage you all also to post any questions or comments. We will have time at the end of this to address some questions. Feel free to come off mute as well at the end. This is really meant to be a dialogue, and we invite you to join that conversation. So I want to introduce our three speakers today. I'm so incredibly honored that they agreed to join us today and talk about the great work that they are doing. Wendy Bailey is an adjunct professor at Wilmington University and a trainer and educator with the Diabetes and Heart Disease Prevention and Control Program for the State of Delaware Health and Social Services. Wendy received her BS in Education from the University of Delaware and her graduate degree from Millersville University. She has over 40 years experience working with education and behavioral health in local universities and colleges, state agencies, community-based programs, and work sites. The last decade, she has focused on public health in the area of diabetes and heart disease prevention and control. And in the last year, she has served as the Delaware HHA BPSM Program Facilitator Coordinator with over 60 program facilitators trained and over 270 participants in their first year and a half of operation. A little bit about the HHA BPSM. They offer free to all qualified Delaware adults with hypertension, and a validated blood pressure cuff is provided to all the participants and facilitators. Welcome, Wendy. Our next presenter, Dr. Rahul Deo, is a co-founder and chief medical officer and head of product at HTN Health, where they are building an AI-enabled platform for comprehensive care delivery, focusing initially on cardiometabolic disease, but more broadly on conditions at the interface between primary and specialty care. Prior to that, he was an academic cardiologist, most recent an associate professor at Harvard Medical School and associate physician at Brigham and Women's Hospital. Welcome, Dr. Deo. Jim Lee is the executive director of global medical affairs at Omron Healthcare, a world leader in blood pressure monitoring and personal health and wellness technology. Jim is in charge of global clinical strategy implementation and manages important relationship with clinicians, institutions, and professional societies. He sits on the International Standard Organization Committee in setting up accurate standard for blood pressure measurement. As a core global member, Jim's role contributes to Omron's bold mission of going for zero, the effort to eliminate heart attack and stroke through groundbreaking technologies that encourage and enable heart-healthy behaviors and sharing of data to improve health outcomes. So again, welcome all. Thank you so much for participating in today's discussion. So what I like to do is get us started. This is for Jim and Rahul. Either one of you can go first. Tell me why you started with Omron and why you started HTN Health. What problems were you trying to solve?
Well, thanks a lot and welcome everyone. My name is Jim from Omron, and it's an honor to be here to share some of the my experience and insights. I will say I joined Omron almost 20 years ago, so it's a long time ago. At the time, 60 million people in the US are hypertension, according to the JNC 7 guidelines. So I joined Omron is try to tackle that huge number of patients, like to support them, give them the best tool to control their destiny. And 20 years later, that figure becomes 116 million according to CDC. And that number doubled, so which means more and more people get hypertension. And the tasks become even more demanding. And our goal is try to help the people, empower the patients, and using the self-monitoring blood pressure tools to empower them to be part of this solution. Instead of that's a task for the physicians, it is that the patient gets that awareness, be part of it, and that can lead to a better control. So the reason I joined Omron is try to tackle that problem, and the mission is still ongoing, and I'm very excited that more people join this kind of effort. It's a roundtable. It is a great kind of effort to team up. So that's my kind of story behind this journey.
Thank you, Jim. Dr. Deo?
Thanks. That was great to hear, Jim, and very inspiring. I have, it's a little bit of a different story in that I spent some 20-some years in academia and taking care of patients as a cardiologist, in addition to doing a substantial amount of research. But one of the things that was clear is that chronic diseases, and that includes hypertension, but also diabetes, heart failure, they're just really hard to manage and treat. And it's too much. And for so many reasons. One of them is that the amount of time needed is just way more than is sort of supported in the current system. These diseases often need multiple steps in terms of medication changes, multiple medications, multiple measurements are being tracked at the same time. Side effects develop, patients have so many questions. There's just so much that is needed to be able to do this effectively. And at the same time, the number of medications is increasing, getting more complicated. The number of conditions a given patient had is getting more complicated. So we started a company with the idea that we needed to give some help. And so we built a software platform that can enable a remote team to be able to really fully treat diseases like hypertension at the level of a specialist. But really not using specialists. So using, just as Jim mentioned, the patient is a big part of this, but we're also sort of heavily enabling advanced care practitioners and then non-licensed people. So navigators, community health workers, people who are really there to be able to spend a lot of time talking to the patients, because there's just simply a lot that needs to happen in terms of behavioral change. And so I'm very excited because I feel like, despite 20-some years in research, I feel like we're getting kind of closer to what needs to be done. And certainly empowering patients with measurements at home is a big part of that, because ultimately there's just, this is a slow battle, and so it just needs sort of everybody to be involved in a kind of pattern that's different than the way the healthcare system has supported to date. So thank you, Jenny, for inviting me for this.
Thank you. So Wendy, can you tell us about your work with the Healthy Heart Ambassador blood pressure self-monitoring program in Delaware?
Sorry, I was muted. Thank you for asking, Jenny, and thank you for inviting us to be here. Delaware wanted very much to supplement the public health work that we were doing to reach the hypertension goals for the country. And so we looked around and we did a lot of mainstream and a little upstream work with provider practices and working with Quality Insights and working with the federally qualified healthcare centers on blood pressure loaner programs and medication therapy management programs, and collaborating with the American Heart Association for their Target BP program. But we believed that we needed more. And then the CDC offered us an opportunity for state departments to participate in a Train the Trainer program. It was called the Healthy Heart Ambassadors Blood Pressure Self-Monitoring Program. And what that does is it allowed two Delaware Diabetes Heart Disease Prevention and Control internal staff to train, plan, prepare, and deliver the Healthy Heart Ambassadors program in the state of Delaware. The program allows for each participant, and they can be referred themselves or referred through their physicians or their healthcare centers, but it allows each participant to have an Omron Series 5 Bluetooth-enabled blood pressure battery-operated portable cuff that they keep for their lifetime. They learn how to use. They're provided with 8 coaching sessions of about 15 to 20 minutes each, with an opportunity to talk about what the numbers mean, to answer questions that they have, to help them to get in the habit of accurately and reliably measuring their blood pressure on a continual, systematic basis, recording that information and then sharing it with their healthcare providers, which was phenomenal because it reaches a good portion of our population and allows us to expand our effort in the work to proceed with hypertension control. We launched the program within 6 months of the CDC's offer, and we used tobacco settlement monies to provide the Omron Series 5 cuffs to all the participants. And we marketed the program again through the provider practices, through the healthcare systems, through our Medicaid managed care organizations. And we did some direct marketing too. We directly marketed for populations of focus with print and social media campaigns. We enhanced the program a little bit. We added some Delaware-specific resource information at the end of the nutrition education. So each participant gets their cuff, they get a coach, they get 8 coaching sessions over 4 months, and then they get 4 nutrition education learning opportunities. And then we enhanced it even further by adding, with the Cooperative Extension and the American Heart Association's Simple Cooking with Heart, a cooking and nutrition experience or demonstration. People could see that virtually, or they could participate live in the cooking and actually make heart-healthy recipes together, and then enjoy the recipes and learn how that can easily fit into their lives. So some of the Delaware-specific pieces that we added included our self-management programs like the chronic disease self-management, the diabetes self-management. The Delaware Pharmacist Society has an MTM program that's available to all citizens of Delaware for free that have hypertension. We talked a lot about the Walk with Ease, getting people out and moving more and getting some exercise. We talked about the National Diabetes Prevention Program and DSMES as additional opportunities for people to make healthy lifestyle changes. And we have a research project that's going on throughout this, and we're very excited with our initial look at the data. But we will be researching our effectiveness, and that will be published sometime in the next year and a half. And we're looking to expand. We hope to expand exponentially by creating an umbrella hub concept for this, where we continue to provide a lot of the data management and internal structural pieces of the Healthy Heart Ambassador program, but allow managed care organizations, healthcare systems, or large community-based organizations to brand it as their own and take it to their own population. So we're really kind of looking to send it out to the world now that we've kind of figured out how well it works and what are the best parts. And so this has been our pilot year and a half, and we're very excited.
So if I can ask a follow-up question before we move on to the other questions, what has been your biggest aha moment in the last year and a half? Because you're doing amazing work in this state and you're getting a lot of kudos in the chat box. I know you probably can't see that, but what has been your biggest aha moment?
The most amazing thing about it to me was self-monitoring of your blood pressure, a little bit like monitoring your food and logging it, or monitoring your exercise and logging it, works. Just works. It lowers people's blood pressure. Just learning that relationship between my life and my blood pressure is amazing. Then helping people connect that information to their doctors in an effective way that allows their doctors to be able to not stand there and try to calculate averages out for people looking at a list of, but with the Bluetooth Omron blood pressure cuffs, they're able to connect to their phone. The app records their blood pressure and will give them weekly or monthly or yearly graphs of their systolic and their diastolic numbers. And it's just that technology has just allowed a much better communication and healthcare provider access to good information.
I think what you said was so simple yet so powerful that it works, right? I mean, you're seeing in the year and a half, and I invite Rahul or Jim to comment on that because you're both in this space as well. And I'm sure you're probably wanting to nod your head vigorously and be like, yes, we know. But, in both the work that you do with an Omron and Admin Health, I'm sure you're seeing the same type of results. And I don't know if you want to share, either one of you, on your experience about it works.
Well, I mean, that's great experience. Congratulations, Wendy. It's great. Let me just use an analogy. I think that might be very much capture this kind of experiment or experience. So, like, I think I see this kind of a patient more like a passenger in a car. So you ride the car, the doctor's in the driving seats. The doctor prescribed the medication for you. You can take it, or sometimes patients do not, because 1/3 of the prescription was not filled on average. And part of it is hypertension drugs. And then even filled, not all medication will be taken. And patients skip it, right? Because they are in the passenger's seats. And imagine, now if you empower the patient starts to see the results of the medication, see the results of their blood pressure, and then they become empowered. Now it's a swap or a switch. The patient is in the driving seats. And then used to be like the hypertension we call the silent killer, which means the patient do not feel if the blood pressure is high or low. I mean, extreme situations they can feel, but normally they don't feel. So it's a silent killer. And if you drive the car without those gadgets to show you the engine temperature or the speed, and then you are driving a car with danger, right? But you don't know. This is a perfect picture, which is by give the patient the tool and knowledge, and then they can use the tool to see their hypertension condition and proactively taking the pills and see their blood pressure under control. So that is the perfect situation for the patient driving a car, and they know their destiny. They know the readings on the dashboard. So the car is a great condition. They are reaching their destiny safely and happily. So this is what I see. That's a great story, and I just want to pitch in on this analogy.
Thank you, Jim. Rahul, do you want to add anything from your experience?
Yeah, I want to strongly echo, but also give sort of a similar story. So we've been working for the past almost 9 months in Detroit in a program that is jointly sponsored by UHG, Resolve to Save Lives, and working closely with DABO, Detroit Association of Black Organizations. And there it's a kind of community-based program where in this case cellular BP cuffs are being handed out to patients. And I've been the physician sort of in charge of it, working closely with community health workers and care navigators. And the same thing that I just heard from Wendy and Jim, actually, I just keep on seeing again and again, which is as soon as people start to see the measurements, there is a sort of some of course deny it and say there must be something wrong with this device. But for the subset that actually sort of, are come to terms with and accept it, there's all of these changes that start to happen. Prescription bottles that were already in the house that were being taken infrequently start taking regularly. There's a change in mindset around diet. There's a change in mindset around introducing exercise. And the irony is that, often we would hand the cuff out, and then it would take us a little while to actually get and talk to the patient. And then we would just watch in the interim before even starting anything, we would just watch the blood pressures just coming down over the span of 7 days, 10 days. And, it's a little bit humbling because I'm like, well, what am I doing then if all I've done is handed out a blood pressure cuff? But at the same time, it's very heartening to see for some people. But I think that there's one more thing to it that is probably has to also be said, which is that it's still there's still a kind of a collaboration here that's going on that also needs to be maintained. So for those people where it isn't enough, and that, let's say, the current medication that they're on is not enough, and the current lifestyle changes they introduce is not enough, there has to be ongoing participation by the providers to kind of meet patients where they are at the frequency that they need to, because otherwise there's nihilism that sets in. You start measuring and then you're like, well, I'm watching this, it's really high and nothing's happening and nobody's giving me anything and my appointment's not until 6 months from now. And I think that's very discouraging. So I see this as the first part, which is, empower the patient. But the companion to that is at the sort of the same frequency, not the same frequency, I mean daily, but at the interval of which an intervention can work, that has to be the time to sort of make the intervention, check in, see what obstacles there are, make another change. That has to happen at the pace. And so, I mean, I think that's very much what we've tried to empower, is to kind of to accompany this sort of home-based monitoring with some measure of actual sort of system to be able to keep up with it, to make the changes that are needed. So I think I want to add that only because I think that it also is sort of essential that if the rest of the healthcare team is not helping out, then we're going to get back to where we were, which is sort of a little bit of despair that I see a number I don't want to see and I have nothing that I can do about it.
That's right. That's right. And just a side note, you are all getting a lot of questions in the chat box. You don't need to worry about it. We are monitoring it behind the scenes, and we will try to get through all the questions at the end of our questions and our dialogue. So to those who are posting, thank you. Keep posting the questions. And to our wonderful presenters, you don't need to worry about it. We will verbally ask you these questions that are coming through because the chat box is on fire. So going back to you, Rahul, you are a cardiologist by training. We have lots of cardiologists on this virtual chat right now. And one of our co-chairs, actually both of our co-chairs, Dr. Jaime Murillo and Dr. Marile Unagini, are both cardiologists by training as well. So what were your aha moments when seeing patients that led you to your transition to start Atman Health?
So I think actually, because I was been indoctrinated in the system for a long time, it's a little less aha and a little more heresy, which is that the sort of a recognition that the system that's currently there is not the best one for the patients when it comes to these diseases. The sort of episodic, infrequent interventions, and then check in again at some 6 months or a year from now, potentially sort of different people taking on different parts of things, even though there's plenty of crosstalk that's going on and no unifying message. So the thing that might be a good thing for doctors in terms of convenience is not necessarily, or is not, maybe I'll be a little more strong about that, is not the best thing for patients and for these diseases. And so I think that sort of required a realization that was what was good for me sitting in my office, wasn't actually achieving what needed to be achieved. And if your goal is actually that, rather than to have sort of a kind of a comfortable approach, then you need to find some way to change. So that's, I think, the first thing. Second bit of heresy, which is also that there's a lot we don't know, and there's a lot we don't know about who will respond to which medication, what side effects set in, what behavioral changes might work and won't work. Could we predict these things? And I think one of the things that we found once we're involved in this program, and really some other programs, is that when you do empower somebody with a cuff and you set up this kind of like contract with them, you have some expectations to be effective. And so if you're not, let's say the meds you choose aren't working well, or so, you feel like they're doing their job, they're measuring, they're changing, they're doing their things, and so that it feels unfortunate that there's a lot of, unfortunate not the right word, but there's a lot of gaps in knowledge that I think can be overcome by some degree of this sort of rapid feedback cycle where data comes, changes are made, you observe what happens. And there's so much I think that the medical profession can benefit from. And it just, again, the sort of historical way we've done things hasn't allowed that to happen. So I think those are the two heretical things I'm going to say, but both of those are things that really sort of, built up over, let's say, over a decade or so, and said, maybe we need to do this in a very different way than we're currently doing.
That's great. Thank you. So you may be familiar with this, but in public health, we talk a lot about improving hypertension control rates to 80% by 2025, which is only a few years away. So from all of your perspectives, do you think SMBPs will help us reach that goal? And do you think we, as a coalition of multiple different sectors at the table, should be considering anything else? And who are the partners and collaborators that need to be at the table as we consider solutions? And I know I just asked you a lot of questions, but this is open to all of you to provide your expertise and perspective.
I would like to see that the programs like self-monitoring, Healthy Heart Ambassadors become sustainable. I would love to see some coverage for cuffs beyond the grant cycle or the settlement dollars. And I would love to see, I think I like Jim's analogy the best. I think I'd like to see chronic disease managers driving their own car.
Jim or Rahul, anything to add?
Yeah, I can add some comments. I agree. I mean, the patients is center. So the patients, they are, they have the doctor, of course. That's important to give the guidance, give the prescription, and give the suggestions. And then they have their loved ones. They have their spouse, their children, and who are very supportive and caring. And then they also have their companions. For example, I heard a lot of good stories like the barbershop, like a study, right? So, which is similar experience patients or people when they share in the community, and that can empower. And finally, it is a tool and knowledge. The knowledge is awareness of their condition and as a resource they can potentially tap into. And then finally, that's a tool. The tool is the self-measured blood pressure monitors. And then for those need to be accurate, because we will touch on that topic later, and then need to be ease of use, which means it cannot be too difficult to figure out, because we Americans, we do not want to read instruction manual. The product need to be intuitive enough to open the box, easily put on, and there's no choice to say, hey, is this a large cuff or that's a small cuff? It should be one cuff, fit the majority of the population, remove all the burden from the patients, so that this can be an easy selection and easy solution for the patient. And then another piece Rahul also mentioned about is about the habit forming. So it takes the patient about a couple months to form that habit, and then that habit will stay. But during that period of time, need to have some encouragement, need to have the tools easy to use, need to have the loved ones to encourage and push. So all that is important. So I think those takes a lot of like a team, as well as a good enabler and a good tool to realize that habit.
Rahul, anything to add? Yeah.
No, I'm gonna again echo it. I think it's what Wendy said. I'm also worried about, which is that there can be lots of pilots, but what's the sustainable model here? And I think there's actually two things that I think that are challenging, that have been what I would say a big part of the success for our model. One of them is the expense of the cuff is one that, currently, given certain sort of payers, it's either covered only for ambulatory measurements to just confirm that it's not white coat hypertension, or in some extreme, sort of more extreme cases, but there's a lot of people in the middle who might not benefit. And the second is we benefit a lot from the sort of high touch element that's coming from non-licensed individuals. And, there's certain billing codes, for example, there's CCM within Medicare, and certain kind of situations where that activity can be reimbursed. But if it isn't, then it starts to regress again into the sort of, well, when you show up to the doctor's office, then maybe somebody will sort of, do something at that point. And I worry that as soon as that starts to happen as the norm, you have this disconnect between the sort of the measurements that are happening and the changes that are taking place. And so a lot of these other things that I think are needed to be able to sustain that relationship, which is, coaching through the change that's needed, all of that is time consuming. And if it's not reimbursed, it's going to go away once the pilots go away. And so and I also think that the from the payer perspective, if something is expensive and at home and not being used because nobody else is sort of supporting its use in all the other ways it's needed, that's not going to last either. And there's going to be some disillusionment around that too. So I think there's sort of everything has to click for this to work from a solution rather than individual parts. And I think that the pilots allow it to click, but they subsidize it to click. Right. And I think it can't be that. It has to be something where the sort of the different pieces, when they can come together, are rewarded as such, and then it will be sustained rather than it being sort of these transient glimpses of success and glory that then sort of fade into something else.
Yeah, and to follow up from that to Wendy and Rahul, I know, Rahul, you work with Resolve to Save Lives and United Health Group in Detroit. You mentioned that. And Wendy, I know you're collaborating throughout the entire state. What can you explain or share a little bit about your experiences working collaboratively with United, with Resolve to Save Lives, and the impact that has, through that collective action? And Wendy, I know you mentioned too, I don't know if you work with any payers or have relationships with them beyond the grant that's given to you from the CDC to really implement this program in a very meaningful way. So I don't know if either one of you want to share your journey or experience with working across sectors in certain areas in Delaware and then in Detroit.
In Delaware, we've been working with our managed care organizations to expand the availability and coverage and referrals into the diabetes prevention program. Mm-hmm. And I'm hoping that we're going to be able to kind of mimic those same efforts and bring the Healthy Heart Ambassadors program on board. We work very closely with AmeriHealth Cataris of Delaware we provide the training for their facilitators so that they can provide the services for the people that are covered by their insurance. And that's worked out very well for us. And that's where the beginning idea of this umbrella hub started to blossom, and we got excited. So
that's great.
Yeah, I'll add that. So we have three partners, actually. We have United. So Jaime Murillo is sort of heading things up at United, and we also have Resolve to Save Lives. I know Liz Ortiz is on the call here, and then Detroit Association of Black Organizations, DABO. And the pieces there, I'm going to speak less about the sort of the payer side of things and more about the kind of the pieces that were necessary for what was largely an under-resourced population, still succeeding in terms of managing blood pressure. I mean, we were able to get 85-90% of people under control in about 2 months or so, 2 to 3 months or so. But there it was sort of a trusted local kind of community partner, a place that, a group that could help with some social sort of issues that might come up in terms of transportation problems, other sort of things that might be obstacles towards care. And then, lots of just putting minds together to think about what are the What are the things that get in the way that might be an element of trust? It might be an element of, there's a lot of things that have to be, like I said, this is a partnership, right? So the patients have to believe that somebody is there for them, somebody is going to sort of support them through the things that matter to them. And so if it doesn't resonate that way, it's not going to work. And so to the extent that those pieces can come together, this has a much higher likelihood of succeeding. And it's hard to break it down as to what pieces are working, in the sense we throw it all together at the same time. But I do think the sort of sense of like, somebody's there for me, somebody's easy to contact. If I have other problems, I can talk about those and they'll try to solve those too, if possible. There's a place to go to if I'm having difficulty. We did actually give a cellular enabled blood pressure cuff, because many people didn't have smartphones that either they knew how to use or that worked, or so I think that those, and it wouldn't have been everybody, but I think that in that case it ended up being probably a very important thing to be able to sort of get everybody going without necessarily having much technological expertise too. But I see some of those comments too. It's like all of this has to come together, because otherwise you're going to have some sort of weak link, and something will not succeed.
So I have a few more questions, but I actually want to pause my questions because there are so many wonderful questions that are coming in the chat, and I want to make sure we have time to answer some of them. So Kelly, I don't know if you want to throw any out, or if you want me to open up the chat box.
Yeah, I can go ahead and I can start maybe with some of the questions for all. There are so many questions. I'm not sure if we'll get to them all or not. So maybe our esteemed panelists won't mind providing some answers written, and we can provide those back to the group. But I want to start with this question that was just asked by one of our esteemed chairs, because I think it really gets to the heart of what we're talking about. And that is, how do we ensure equitable access to SMBP? So I don't know who wants to take that one first.
In Delaware, access is available to anybody for free that has hypertension or is on hypertension medications. But in order to make it a more social justice frame, we are looking at targeting our marketing for this and pushing it out to populations that we think are affected by the social determinants of health. And so we look at our rural populations, and we look at our extreme urban populations, and we look at our elderly, and we look at all of the people that are covered by Medicaid or Medicare insurances. And we say, how can we reach these populations and really focus in on connecting with them in meaningful ways. And I really do like that the community organizations are trusted resources for many of our faith-based populations. So we can really, as we expand, we can allow them to reach their populations as well. So.
Jenny, there's a quick follow-up for Wendy that I think is relevant. And can you answer, through what mechanism does Delaware make cuffs available to all?
Right now, the only means that we have to do that is through some state funding, and it comes from the tobacco settlement dollars.
And going back to the equitable piece, Jim or Rahul, if you want to add to that.
I don't have anything to add on the policy side, except that, in this last 10 months or so, I've been shocked at just how high these blood pressures are in young women in their 30s and 40s. I mean, it breaks my heart to see these are symptomatic stage 3 hypertension in young women and young men. And so I think there's a definite need for it. I just don't personally have any real idea as to how we can make this sort of equitable and distributed. It's just that it's clear that there's an urgency to doing it, because it's probably the people that are the worst off that have the most sort of malignant disease in terms of that. So it needs to be addressed.
Jim, any thoughts on that?
Yeah, I mean, a few years ago, a professor or a doctor at the University of Chicago approached me about the program to help the underserved teenagers who are pregnant. And then eclampsia is a major kind of a problem because they are not only not affordable, but also they are in urgent need. So she actually created a program and even reached to the national level, and then try to get some fundings. And Omron also support in that kind of effort. So I'll say it probably takes some case by case, and also take some kind of the society's effort to address some urgent needs for those like. For elderly hypertension, it is everybody understand, but for the young underserved population, and that is a great kind of urgent kind of matter. And on the twist of the flip of the coin, if the young lady gets the help and get the knowledge, that will carry through the lifelong kind of experience, because this lady will be the wife, will be the grandma. So this kind of education will benefit the entire family or their like relatives. So I mean, that is something I see an urgent need, and need some society's help to promote and to help and to support a lifelong kind of. It's more like a mouse, the word of mouth, to educate, to share experience, to be the change agent. So I see the urgency, but also see the great opportunity on both sides.
Thank you.
I love that concept, and somebody mentioned it in the chat. If we could get our young people involved, maybe before they graduated from high school, it's easier to build healthy people than it is to repair people that have chronic conditions. So maybe that's something that should go into our health curriculums.
I totally agree. The best medicine is the prevention. Prevent the disease, become disease is the best medicine. It's better than any best surgeons, because you don't want to repair. You want to maintain a healthy body and healthy lifestyle.
That's absolutely right. Kelly, do you have any? I know you have a lot more questions that you've been collecting.
Yeah. Do you want to open it up, or do you want me to go with some of the ones in the chat? Because there are a lot.
Let's go with some more in the chat, but I also
Okay.
encourage anyone to come off mute if you feel comfortable. If not, feel free to type in the chat as well. But yeah, we can go through some of these questions in the
Okay.
chat box.
Here's a really good question. Again, this is for all, and a little context. The commenter wrote, in Maryland, we've had little success with Bluetooth monitors communicating with primary care EHR systems. Any progress nationwide? And I'm going to post that in the chat too, so you all can see that.
So we rely on our participants to communicate with their medical providers, because there are so many different EHRs out there in Delaware that it's an uphill battle to try and get technology to communicate with different pieces. We've had some small successes, but we really mostly rely just on the participants to communicate with their doctors.
And I can add some comments. At Omron, we recognize that kind of dilemma, because there's two type of needs. One type of needs is for individual patients. They are the consumers. They probably purchase the device from the store, independent, with doctors on site or nurses on site. Even sometimes doctor makes the recommendation. That's important. And then Omron has to create this database and using in the cloud, and then also it's a HIPAA compliant with the Bluetooth enabling device, and so easy to pair with the cell phone, and then get the data upload to the cloud. So the patient can be in charge, so that they can see their trend, they can share with the doctors. So that is definitely a basic needs. So all the devices which is connected is always enable that function. And then there's another type of needs, which is just like the question. A lot of times, the data from the device and the EMR system in the primary doctor or the hospital, it's always a very difficult kind of integration. So we create the program called Vital Site. It's a Vital Site remote patient monitoring program. So the basic idea is to have the device which is with a patient, and the data can go through a middle piece. Could be a cell phone, could be a middleware. It's through the Bluetooth connection, and then through that piece, in this case, it's a cellular hub. So one side is Bluetooth connect with the device. The other side is the cellular going through the hub and to the cloud, which is integratable with the EMR. And this program has been successfully launched in the nation. And then it's already in Mount Sinai Hospital, at Northwestern University Hospital. So there are quite a few kind of sites is already successful. And the team at Omron and also the hospital IT can work together to resolve this kind of IT integration, and this become all smooth. So this kind of a remote patient monitoring program is reimbursable under the Medicare. So it's a very good program, and the patients at the home, their data can be on the dashboard or in the EMR system, and then you can set the alarm so that when this reach the alarm status, the nurse or the healthcare professionals can call the patient or follow up, or a lot of actions can happen with this kind of system. So I just want to make sure this kind of a system is available, and I can post my email address so that you can follow up with me, and we can I can connect you with the right team at Omron.
Thank you, Jim. We appreciate that. I'm going to insert a question here that I had to you all. So as you all know, and I've mentioned this several times on today's Fireside Chat, the NHCR, the Roundtable, is a coalition of many different sectors and organizations, and with many individuals working and advocating in the SMBP space. So what would be your key takeaway message to everyone listening when it comes to SMBP, either based on your experience, on your partnerships, things that we should be considering as we move forward as a coalition and how we are going to address this collectively?
My takeaway and the message that I just want to put out there for everyone is that this really does work. Let's keep it going.
Yeah, my take on this is the device need to be accurate, because that is the first and utmost kind of requirement. And there's a clear guideline on how to validate the device. So validate device listing is a good reference. It's initiated by AMA with a group of professional doctors and researchers at the committee. And they have a set criteria for the evaluation. It's a rigorous program, and it can be trusted. So that is number one on accuracy. And number two is, again, as I mentioned, it needs to be ease of use. It needs to be comfortable, not causing too much pain, and smart enough to tailor into each individual patient's blood pressure level. So at Omron, we have IntelliSense. It's a kind of a technology to not inflate the cuff, causing unnecessary pain. So because if that is too painful, a patient will be reluctant to measure BP. So, and also it needs to be connected so that the data can be shared. So a lot of things in the nitty-gritty, but once you remove all the barriers, and then the patient can enjoy the ride for the long time. And finally, it is also about finally it's about the readings, not about the monitor. The monitor is just a tool, but finally it's a reading. What does that mean? What's the meaning of the systolic BP, diastolic BP at what level? And what does that mean with their lifestyle, for example, diet, or their habit like drink. A lot of time, coffee drinkers, you will see the spike if you do the experiment. So, and then for the patient, they can have a choice when they understand that mechanism. So the knowledge is a powerful enabler for the patients to adopt the healthy lifestyle, adopt the medication adherence. And that is the great kind of thing, lead towards a more productive and more healthy destiny. So that's probably my take on that.
Thank you, Jim. Rahul?
Okay, last point I'll add, I absolutely echo what others have said, but I worry that we create more data, but we don't necessarily have a system to act on it. And I think that there's sort of provider fatigue about more and more stuff coming in, and they're sort of not supported to be able to handle it. There's already plenty of physician burnout. And so, I think the question is like, where does it go, and who's going to act on it? Because otherwise there's going to be lots of expense on the measuring side, but not enough support on the action side. And so I think this comment around EHRs, that's the beginning of it, right? Now we're talking about potentially separate systems, separate dashboards, two sets of streams of data, things are happening asynchronously. And so I think that this is a problem that if it's not solved, I think that what's the worry is just that there will be disillusionment with the device if we aren't thinking about all of the other parts of this too, because otherwise there's going to be a sense of, oh, we spent on all of this, but we're not really seeing the returns. So yeah, who's going to make sure that there is a solution at the other side, that when the data comes, that it's actually going to be acted on in a way that sort of meets the needs of the disease and the patient. So that's sort of my sobering thought on top of everything.
Well, I have a sobering question that was just posted in the chat as well. So what would you each say is the number one challenge to getting compliance to SBMP? SBPM, sorry.
We've seen great sort of actual I mean, we actually have our navigators reach out and remind people, but we actually see great compliance. Great. But we see it because there's actually, I think, a lot of give and take going on around what those measurements mean and what will happen to them. So medication changes are made in 10 days, advice is being given. There's a partnership there that's high touch. And so we haven't really seen much problems with compliance and measurements, because I think there's a sense that there's a reward that will come from measuring. And I think if there's no reward that's coming from measuring, then yeah, you're going to find some cynicism around that, and maybe rightfully so. So I think it's all about whether there's a system or whether it's just a sort of an isolated ask without much kind of quid pro quo coming from the other side.
I agree with Rahul that you need that several months worth of connection in order to get people engaged and to continue to monitor. It's more about that understanding why and how it works and seeing the results and actually getting that positive feedback that really helps people to continue to do it. Sometimes we see life get in the way. People get sick, the flu, COVID, I'm going into the hospital. I'm having, other conditions that are overriding my blood pressure right now. But for the most part, with that engagement with a coach, people are very compliant. It's actually almost a mute column now for us to say, did people monitor between our visits? Because it's almost always, yes, I've put one no down once, and that's in a year and a half.
And in my opinion, there are two kind of moments probably is challenging. One is the decision is to get a self-monitored blood pressure monitor and try to shop for one, because which one is better, which one is good, because there's no experience. They need some help from their friends, from the doctors, or from their loved ones. So once this step is taken, and then it is like a start to measure. It's a great thing for the first like a couple of weeks. And then the challenge comes is, this can be sustainable? I mean, you don't want to measure for 2 weeks and put into the drawer, forget about it, and then the story will end. And so the sustainable, and then use it for routinely, not necessarily to be every day. But if the patient do not use it for at least a couple of times a month, this habit will end. So all that, I think, is a big challenge for the patient side. I can see with the device.
So before I ask you for one final takeaway, I just want to remind everyone, or let's share it to everyone, that we have some wonderful resources on our website on SMBP from the American Heart Association, is letting us share some of the resources, and the CDC has put together a amazing list of resources. So I encourage you, if you are interested in seeing the resources we have, to go to our website. We also have a short survey that we posted in the chat box. It'll take less than 10 seconds, I promise you. If you could fill that out, that would be great. But before we end, I just want to first thank you all. This has been a wonderful, wonderful conversation. And I so thank you for the time that you took to present to us and talk to us around our virtual fire. Any last key takeaways around the work that we're doing, the work that you are all doing when we, again, think about SMBP? And we can just end it on it works, because I love that again so much, that it's so simple but yet so wonderfully powerful, that we're seeing results in the work that you are all doing, and the products that you're developing, the collaborations that you're doing, and the partners that you have. So anything else to add from Wendy's amazing statement of it works?
I think it works, but it's also a model for a number of diseases, that, this idea of empowered patients, self-measurements of something, right? It could be symptom reporting, it could be whatever, but ultimately and then some sense that somebody's listening and giving some sort of action advice, or doing something on the other end. And then that cycle is incredibly powerful, and people have a new mindset around what the care system is like. But it needs to be, it's remarkable how you can actually change your perspective on what it means to be a patient. But it just requires all those things to click, and we don't want it to all vanish once the subsidies sort of disappear. And so I think it's important to think about the fact that it works, but that it needs to be sustained.
So true. Jim or Wendy?
Yeah, from my perspective, I'll say hypertension is a silent killer, and it is one of the cardiovascular disease. And a lot of time, the patient not only have just one disease. It could be a diabetes, it could be the AFib, it could be others. So definitely need to consider this holistic picture. And then at Omron, we also try to do our best to address that. That's how we say going for zero. It is the going for zero events for heart attack, for the stroke, because our aspiration, our mission is going for zero. And that also inspires us to provide the innovation and to provide some of the not only the product, but also process. For the product side, we have the blood pressure monitors and the ECG into one body. That's a first ever device, which is you can measure your blood pressure monitor at home with a cuff, but also have the ECG functions on both sides. You can do that. And then we also have this watch type is anywhere, anytime. You can measure your blood pressure in a very quiet condition. So this innovation is into this device side, but also innovation into the process side. I totally agree with Rahul's early comment. If there's so many data pouring into the system, it's the huge burden for the doctors as well. We have to consider that. So the remote patient monitoring is try to set up the alarm. So which means it's autopilot, just like you take the airline, the pilot will be doing this autopilot during the majority of the time. Only takeoff and touchdown need a close monitoring. Same thing on here is if there's AI, if there's some system to sift through a lot of normal condition, no attention need to be paid. However, once it's an alarm, then the healthcare team need to address that person at that moment. So that is a kind of remote patient monitoring, also very helpful. So Omron is working with the team here and try to provide the best solution, tools, and process for the patient and for the doctors. So that's how we are here, and I'll be very welcoming any comments to push us to the next innovation and to the next great product. Thank you very much.
Thank you, Jim. Any last words, Wendy? We're at time, so any quick last words?
If you get a chance, join SMBP. It's a wonderful experience, and it gives you a lot of power as a patient to control your own conditions.
Great. Well, thank you everyone so much. Thank you again to the presenters. This was a fantastic dialogue. We will be sending out the recording in our newsletter and also posting on our website. So I hope everyone has a wonderful rest of their day and a great holiday season. And we hope to see you at our next Fireside Chat. So thank you so much. Thank you.